15 minutes and you have to attempt almost around the 15 to 20 questions. So you should, your approach, your all preparation should be like fast enough to give answers immediately there. And according to me, and you will have 50% of the answer in the scenario itself. And as soon as you see the image and then the scenario, the 50% like will be done there. And other 50% is whatever and you have put effort, whatever you have understood till now, and how exactly you do practice in the ICU, all that actually matters a lot here. It's not like theory exam, what you sit and read for the EDIC part one, the part two is entirely different.
Yeah. So welcome, Dr. Jitendra. Dr. Jitendra is our core faculty from Bangalore, Apollo Hospital, and he has joined. Hello, Dr. Jitendra. And Dr.
Hello, sir.
Manjunath is the core faculty who will be discussing about today evening's all the proceedings. Dr. Manjunath is the chief consultant, critical care at Manipal Hospital, Whitefield, Bangalore. So with me also Dr. Sanant Kumar Das from Australia. So he is traveling, so somehow he will not be able to join. But yes, definitely we'll have a very interesting session coming up. And as Dr. Manjunath has highlighted, I will be just like giving you two lines that it's not the hard work, it is the smart work that counts. And in this type of exam, where totally you will be getting 2 hours or so to clear the EDIC-2 exam. So pass and fail depends upon only 2 hours, and that whatever you have learned over like so many years of your critical care as well as medicine or anesthesia, that will be all tested. So it is, I would say, not very enough time to assess somebody's competency, clinical decision skills, and answering like the way, the communication skills, everything. But the examination is like that only. That's why it is one of the most competitive exam in critical care, where you have to show to the examiner the potential within you. And for that, you need to have a structured course, a format, and the practice. That all have to be in tandem. And that would be all assessed in only 2 hours or so. Am I right, Dr. Jitendra?
Yeah, right, sir. Rightly said.
Okay, so we'll be waiting for maybe 1 or 2 minutes more, Dr. Manjunath.
Yeah, sure.
Yeah, because people are joining, so we are dot on time. So we respect everybody's time, the faculties as well as the delegates, the attendees. So we'll be just waiting for 2 more minutes, and then we'll be starting the discussion for today evening. Anyone who wants to share anything at this point of time, you are most welcome. I can see there are like almost more than 40 attendees have
45.
joined
Good.
already. 45, yeah. So excluding the faculties, and believe me, there are many people, many doctors, many colleagues across the globe. They have requested that the Zoom session should be recorded. But I would say the live session is more interesting, because you will be just also going through how Dr. Manjunath and Dr. Jitendra and myself would be discussing the question scenarios and how you keep yourself in the examinee position, because this is just recently conducted 2 months back or 1.5 months back. And there are also scenarios we have also taken from few last year's CCS and CBS. So one point of, like, I would say, disclaimer, that these are not the exact, if you will be saying the exact format or lines, we have not kept, because for the sake of, there should not be any conflict of interest, but we have slightly formatted it to make it little bit unique, and also giving you the message that yes, this is the high yield domain the examiners have touched upon. So, and people are joining, and we have almost 150. Dr. Manjunath and Dr. Jitendra, I would be very happy to share with you the last registration, it touched 149.
Oh my God. Okay,
For
good.
the first time, we have come across a webinar, live webinar, and that for also very specific focused exam, European Diploma in Intensive Care Part 2. So this is something very, I would say, motivating for all the faculties as well as the all the attendees also about like the level of the expectation from all the attendees. So we would definitely try to deliver that in the upcoming whatever like 60 minutes or 90 minutes and also in our upcoming courses. Thank you for believing in us. So now I am just like unsharing myself from the screen. And Dr. Manjunath, you please be ready.
Right, so,
Yeah, Dr. Manjunath, you can share your screen.
yeah, sure.
And I request everybody, if you have any questions at any point of
No,
time,
so I
please
think
use the chat box.
somebody had put a message here, like Tapas, the most important thing we need from the course, a list of important items in each topic. Yeah, fine. See, first I'll be doing the CBS part and the CCS, whatever the recalled in the questions, and after that I have around some under 10 slides to make you guys understand in each system. So what topics to be read and what are the high core topics that it will definitely come in the exam. Okay, so please wait for at least for the, the next 1 hour.
Dr. Manjunath, keep some suspense. Don't reveal everything. So there are so many twists and like no, the scene may change at any time. So keep something. So
Yeah,
I
yes.
request all of you to please glue to the system, your laptop. Don't move here and there because for the first time, something is going to be unveiled. The real EDIC part 2, how the last few sessions or examinations have been conducted. So be
You can
ready.
see my screen.
Yeah, yeah. Your inbox is open.
So PPT.
No, sir. Only inbox is open.
Yeah.
Oh, okay.
We can guess all the senders' names and everything to your inbox.
1 second. I can see the PPT.
Your bank details are also visible.
Think that's the wrong one.
So in the meantime, thank you everybody who are joined from other countries also in the different time zones. In the meantime, Dr. Adil, Dr. Afam, Dr. Ahmad,
Sir,
Dr.
yeah.
Ayaz, Dr.
People is now
Akshita.
seen, sir.
Yeah,
Yeah,
yeah.
yeah, fine.
Dr. Anjali, Dr. Anoop, Dr. Apurba, Dr. Arpit, Dr. Arpita C, Dr. Arva, Dr. Jaglul, Dr. Bhaskara, Dr. Chanama, Dr. Debraj, Dr. Devka, Dr. Milind, Dr. Michael, Dr. Edris, Dr. Farhat, Dr. Hassan, Dr. Kirtana, Dr. Kesab, again two Dr. Kesab, three Dr. Kesab, Dr. Khushbu, Dr. Binay Kumar, Dr. Meghna, Dr. Mehnaz, Dr. Mohammad Raga, Dr. Mohammad Jahidul, Dr. El Sayed, Dr. Nafija, Dr. Nasir, Dr. Nabeen, again Dr. Nabeen too, Dr. Pawan Kumar Reddy, Dr. Pallavi, Paritosh, Dr. Apurba, Dr. Pradipta, Dr. Pranam, Dr. Rahul, Dr. Ranjit, Dr. Rabin, Dr. Rohit, Dr. Pragna, Dr. Saha, Dr. Shankar, Shraddha, Siddharth, Sindhuja, Dr. Sriram, Dr. Srikant, Suganya, Sujata, Sumit, Swati, Sweta P, Dr. Saeed Ali, and Dr. Tarun S. Thank you very much. I just cited the names to know like the countries from where you have actually joined. And over to you, Dr. Manjunath.
Yeah. Hi. So, see, these are a few of the questions which were recalled in the sense our the last batch students they called us and they told us that okay, and this was the scenario, this was the image in the sense. So they told us, and there was some the CT image. It was depicting this. It was depicting that. So with all that and the recalled ideas, and I've set like a few questions and also like a one CCS in the scenario. So so we'll go with the first one. So this is And the ultrasound image, so where the scenario was a 50-year-old man, he's admitted for a shortness of breath, and the lung ultrasound performed to assess an area of the opacification on the chest X-ray in his right lower lobe. So this is the right lower zone ultrasound. So what can you see in this? So this was the image most. So and you can see on the right sided on the pleural effusion, the whatever you can see here, and then comes the diaphragm, and then the collapsed lungs with the consolidation. So you can only say the consolidation or the atelectasis depends on the static or the dynamic air bronchogram. If you have the video, and you can say with the static or the dynamic and air bronchogram. And if you have just have a look on the image, so you can say it is underlying and the collapse consolidation of the lung with effusion. Okay, so this is the of the CT chest, the image. 48-year-old man following a fall from the height suffered injury to the chest. So what all the findings, and you can see in this, you should tell immediately within 10 seconds. So what all you can see here. So this is a CT scan of the chest, and you can see the most pathology on the left side of the chest, and you can see the pneumothorax here, and you can see the subcutaneous emphysema, and you can see all the rib fractures, and you can see underlying the lung contusion, and then comes I can see some tube entering here, and also there is the continuation of the tube here as well. So what all the answers, the CT chest and showing the left side pneumothorax with a rib fracture, underlying lung contusion, and also subcutaneous emphysema on the ICD tube in the intercostal space. See, all this is just to give you a picture how exactly the scenario and the images will be there, and what exactly you have to and look for and answer in the exam as soon as possible. If you do the like a practice of this in your daily practice, yeah, then only you can answer in the exam immediately. And if at all if you think that no, just 2 weeks and before the exam I'll sit and see all the images, no, it will not happen that way.
Just
Okay.
adding, Dr. Manjunath, in between
Mm.
some of the tips and tricks, can you show me the last picture? The picture, yeah. So,
Yeah.
whatever Dr. Manjunath has told, people like can identify the pneumothorax, like the subcutaneous emphysema, the lung contusion. But this is something people normally miss: the ICD entry and you can see at the skin level. So, if you are actually answering everything, then they will be giving you marks completely full mark. This is something like you have to score, I would say, 100% marks. So, if you are actually answering 2 or 3, so you will be getting again, they have their like the weightage of the each option, each mark or each answer. So you should always try to answer maximum as possible in CBS, because you don't know the next questions would be very difficult. And this is something we always like anticipate this type of question in any radio imaging if something is being asked about the lung contusion, ICD and everything. So this is one of the clue that I want to highlight you. Don't get carried out by all these like small things, the pneumothorax and subcutaneous emphysema. Rather also find out something as Dr. Manjunath told, the ICD. So this is very important. Yeah. Dr. Manjunath, yeah, please continue.
Yeah. So see the ICD part, if at all, if you have a doubt in the intercostal space, and you can see the continuation of the image here as well, outside the CT chest. So in the sense, outside the chest. So all these are, though these are the minute details, but this carries a marks in the exam.
So Dr. Said has raised hand. So can you just post any query if you have? Yeah. So Dr. Sanand, welcome. So I thought like you were traveling, so I initially informed also. So yeah. So Dr. Sanand, you want to add anything?
Yes, because I am traveling actually,
Yeah.
and
Thank you.
bit restricted with my talking. But as Manjunath was saying, I think all the CTs has to be made in a pattern, that if anybody can write a pattern about describing a CT abdomen or CT chest, that will be a great thing, because probably I will provide a pattern for CT chest, CT brain, CT abdomen, how to answer in a minute, so that you don't miss things in it. I have just given a gist of the CT chest. How do you look for, or what do you look for in a CT chest within 1 minute? So if you follow a pattern, you will not miss. But if you do not follow a pattern, it will be very haphazard and you'll definitely miss things. That's the gist of it. So I'll try to post pattern for each segment CT. That will be helpful for you guys. Dr. Manjuna, please continue then.
Yeah, sure. Yeah, so you have a 45-year-old male after road traffic accident came to ER with unstable hemodynamics. So the what all you can see here in the chest X-ray, so they have provided. So what I would suggest is you should go with, or in the sense from on the hardware, the whatever you have, and also the findings, whatever you can see here. So what does the chest X-ray show? Describe your initial management. So it is just, I think, yeah, it is or left-sided and a large pneumothorax, and you have underlying uh, and a lung collapse as well, and also the mediastinum is shifted towards the right, and you have ICD tube in place, and also two ECG leads and the endotracheal tube and all that. So, and you have almost tension pneumothorax with also with subcutaneous emphysema. So describe your initial management, airway, breathing, circulation, needle thoracostomy. So this should be your answer. So as soon as you see, you should start with the like findings and then tell all other important things in the sense endotracheal tube, ECG leads, ICD, and some I think the buttons of the I think the shirt or something there. So left-sided large pneumothorax with underlying lung collapse, the shift of the mediastinum to the right, ICD tube in left pleural space, subcutaneous emphysema, the management, oxygen supplementation, needle thoracostomy. Okay. So this is, yeah, this image is not so good, but still, I think so. We had a scenario. You are in charge of a 26-year-old man with a traumatic leg brain injury. The CT scan has been performed because of the neurologic deterioration. So, what does the CT brain show here? What could be the problem? So, what exactly you can see? You can see some. So, if you can, so there is patient is actually the post-op patient. He has undergone a decompression, and then you can see some amount of on the cerebral edema with the midline shift. This midline shift has happened because there is some countercoup effect on the other side with some hyperdense opacity. So with like probably STH, and you have all SH in the like Fox cerebri. So all these are under causes. The status post decompressive craniectomy, the cerebral edema with the midline shift, and the right side temporal STH and SAH along the Fox cerebri. You can see SAH along the like Fox cerebri, and then comes the what is a cause for the what could be the problem? The probably because of increase in the cerebral edema, there is actually neurological deterioration. So what will you do next? And you will take care of all the neuroprotective measures, the hypertonic saline or like mannitol, and then you'll have a target of under sodium levels and all that.
There is EVD also. The EVD tip also
Yeah,
is.
EVD tip.
Yeah. Yeah, and there is also you can like no, you can mention many things. The IVH is also still there. Intraventricular hemorrhage, it is like still here in the two occipital horns, you can see. And this is right frontal horn as Dr. Jitendra has posted, tip of the EVD you can see. And still there is like so much of cerebral edema after the decompressive craniotomy also. So you can see also the ventricles have actually enlarged. So maybe there is some obstructive hydrocephalus is actually happening here. That's the reason why you are still getting the cerebral edema. Yeah. Okay.
Yeah, this is, I think, yeah. So we have a 43-year-old man with like brain edema secondary to diffuse and glioma being treated with the steroids, develops in the shortness of breath. The CT scan of the thorax has been performed in the heart rate of like 110, BP of 85 by 60, and SpO2 of around 89%. So what can you see here? The findings. What does the CT scan show? And what is your immediate management? So you can see there's a filling defect. It is almost in a saddle thrombus. You can see the like a filling defect in the pulmonary artery, the trunk. So which is obstructing like both the right and the left pulmonary artery. So it is under saddle pulmonary embolism. And the patient is actually in the shock and also hypoxic. So immediate management will be oxygen supplementation and start with the thrombolysis. And this is, I think, something very difficult history. The 59-year-old man with a remote history of a stroke, the presented on a medical ward with a reduced level of consciousness, requiring intubation. What are the relevant findings on this and the CT brain? I think I can see some of the like chats, questions, and yeah. So we'll come back to all these questions in a minute. I think, yeah. So, and you can see here, the most of it is all watershed infarcts. If you can see, mainly the left MCA territory and also occipital, parieto-occipital area and also the right temporoparietal area. All these are involved. So this is more of a MCA infarct and also with watershed areas infarct. Just 1 second. Yeah, probably because of the shock, and had a watershed infarct in all these areas. So, and you have the other scenario now. The 70-year-old woman with a history of atrial fibrillation presents to the hospital with a vague abdominal pain. So, what all the findings you can see here? I think the people are answering in the chat. I'll come back to the pulmonary embolism, the question in some time. Anyone wants to answer in the chat? Yeah, I can see. Mesenteric ischemia, intestinal obstruction, pneumatosis, intestinosis, SMA thrombosis. Yeah. All correct, all correct. Yes. Portal venous gas. Yes, very good. Pseudo obstruction. Yeah, this is basically see, and you have the scenario here with the history of atrial fibrillation. It's all the clots which has got dislodged from the heart to the mesenteric vessels. You can see the portal vein, the carrier, and also the intestinal wall has got all the bubble of and the gas. All this is suggestive of the mesenteric ischemia and also some of the thickened bowel wall as well. So yeah, all these are like findings. You guys have answered. So yeah, this is. You are called to the emergency department to see a 30-year-old man, the previously fit and well, who presented with a decreased level of consciousness. He is breathing spontaneously on the 3-liter oxygen per minute, so via nasal cannula. What is the most likely diagnosis and what is the treatment? DK, okay. Can somebody diagnose the full ABG here? What kind of acidosis is this? I and N gap. Apart from that, I and N gap. Apart from that, anything else? With respiratory alkalosis. Ion and gap, osmolar gap, very good. Decompensated metabolic acidosis. Any other acidosis you can see? Mixed respiratory and metabolic acidosis. No. Ethylene glycol. This is very tricky one. So see, this is all well, just to give you a gist of the scenario, like what it was asked in the exam. So with respiratory compensation. So see, once you diagnose high anion gap metabolic acidosis, what exactly you do next, and you will see for the delta gap ratio. So can you guys like see the delta ratio here? Do you know how to check for the delta ratio? The change in the anion gap divided by the change in the bicarb. Anyone? See the yes, exactly. Sumit Gupta. Yeah, high anion gap metabolic acidosis with a normal anion gap metabolic acidosis. So sorry. See the to tell it is the methylene like I think ethylene glycol or the methyl alcohol. It's very difficult because the we don't have all the history here except for a decreased level of consciousness. And yeah, I think the a student when they had sent the scenario as well, yeah, it was like this. So the most likely diagnosis, I would say DK with overcorrection with a normal saline. The treatment I can say is IV insulin with a electric correction. So we don't know exactly the scenario was exactly like this or the values were exactly like this. So, but so until and unless if you have any other the finding here, so we can go with the ethylene glycol as well. But osmolality, yes, and we should check with the formula 2 into sodium plus and the glucose, all that. So with that, it's very see. It is just to give a gist of the scenario how exactly it comes in the exam. So your preparation should not be in such a way that and you will just tell the severe acidosis and you leave it. So always and you will have at least a double disorders or triple disorders in the all ABGs here.
So to add to it, so I think ethylene glycol or methyl alcohol poisoning, you should have a little more history. And we don't have I mean, the measured osmolality is not there. So less
Not
likely that this could be one of the poisonings. Maybe if you had a little more history, then yes, and if they had given osmolar gap, but I don't think they have given any of these two, so less likely to be that. But still, to go with, I think with this much of information and the labs we have, still DKA with overcorrection is what it looks.
Yeah. So I think, yeah. So a 29-year-old lady was brought to the ICU from the emergency department. She had methamphetamines and drank 8 liters of water at a rave party a few hours ago. She had a self-resolving seizure on her way to the hospital. So she has all this, the lab reports here. The white cell count of 7,000. The platelets are actually normal. So then comes what, low magnesium, low potassium, low phosphate. The sodium was low, chloride, and the C-reactive protein was actually normal. So what do you do with this? What is the most likely cause of the seizure? How would you manage the patient? Any answers? No, you will not have so much time in the exam. Hyponatremia. Any specific answer? Psychogenic polydipsia, symptomatic hyponatremia. Yes, dilutional hyponatremia. Yes, 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 yes. Yeah. Hypovolemic hyponatremia. Hypovolemic hyponatremia. ABC and the beer potonomia. Mhm. Okay, okay, okay. I think all of you have come to the answer almost. Hypervolemic hyponatremia. How is it hypervolemic hyponatremia? It's a dilutional hyponatremia. Yeah, agree. And then I think we should have Jitendra. You want to comment? Diuretics, also hypomagnesemia. Hypertonic saline to raise 4 to 6 SIADH with methamphetamine. Okay. Electrolyte corrections. Yes, very good. Symptomatic euvolemic hypo. How do you guys tell it's euvolemic, hypovolemic here? Refeeding syndrome. No, 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 no. Treatment 3% saline. Okay.
Hello?
Jitendra?
Yeah. So that's what, as you said, I mean, you can't comment on the volume status because nothing is being mentioned about the volume status of the person, but it is symptomatic hyponatremia, as you all rightly said, but it is mainly because of low solute intake. She's taken a lot of water, but low solute intake, and because of which there has been dilution of whatever sodium was there. So normal sodium level, but excess of water level in the body, so it's causing dilutional hyponatremia. So that is the right answer. So it is because of decreased solute intake. And management should be like that: airway, breathing, circulation first, anything for any emergency situation. Then you can start with 3% saline because the patient here is symptomatic and having a seizure. So that should be okay. I think the rest of the things, refeeding and all, doesn't happen here. Doesn't suit.
Yeah.
Yeah.
See, the refeeding syndrome, and you will have like a more of respiratory failure and the cardiac failure, and then comes, I think, the seizure. So it's very unlikely to have a self-resolving and a seizure with refeeding syndrome. And I think the people who go to, I think that on the rave party, I don't think so. They will step into a refeeding syndrome. Okay. So yeah, so this is, I think, something to be, I think, to see the scenario itself, it will take some time. You have a lady who is admitted to ICU with a suspected and a septic shock of unknown origin. She is very drowsy with a mean arterial pressure of like 60 mm mercury on noradrenaline of like 0.2 microgram per kg per minute. What are the treatment priorities? So describe the acid base abnormality. Anyone? Calcium chloride, hyperkalemia, very good. Okay. Yes, yes, yes. So you should tell all the acid base abnormalities and the organ injuries and then on the treatment priorities. Mixed acidosis, yes, very good. Bakir Zagul, ion gap with respiratory acidosis, with hyperkalemia, with acute kidney injury, yes, very good, very good. Yes, to treat hyperkalemia, yes. The suspected septic shock, yes. Dialysis, okay. Hemodialysis, okay. NIV, okay. Lactate increase noradrenaline. See, this is the basic scenario what we come across in all our ICUs. So what the most important thing and you do if you have a suspicion of the sepsis and you will see for the source of sepsis, send cultures, start antibiotics, anti-hyperkalemia measures, and also the I think yeah, if at all if it is not resolving with the anti-hyperkalemia measures, yeah, then you consider for all dialysis, other things. Look for the source of infection, cultures, fluid resuscitation, and appropriate antibiotics. The patient has got acute kidney injury, IV hydration, avoid nephrotoxic medications. So look for the post-renal cause. Yes, 1 hour bundle of the septic shock. Yes, very good. Shankar Dorai Swami. Yeah, so I think this is, yeah, the next one. 60-year-old man with chronic heart failure was admitted with a dizziness and edema after a 3-week course of the linezolid for a joint infection. He is alert with a respiratory rate of 25 per minute, breathing room air, normotensive with preserved capillary refill time. So this is the ABG you have. Interpret the lab results and what is the most probable cause. Linezolid induced myelosuppression, yes, very good. Apart from that, lactic acidosis, yes, we know that. What is the cause? Joint infection. Use increased lactates, yes. Secondary to linezolid exposure, yes, very good. Agma with respiratory compensation with normal anion gap. Excellent, like Sumit Gupta. Deranged LFT, yes. And acute kidney injury. Yes, so it is all because of linezolid under toxicity. The patient is actually in multi-organ failure. So he has got acute kidney injury, the liver dysfunction, the raised bilirubin, raised lactates, and also bone marrow suppression. So it is the probably because of linezolid under toxicity. Anyone knows the triad of the linezolid under toxicity? Triad of the linezolid toxicity. Anybody knows? It's hypoglycemia, pancreatitis, and pancreatitis and bone marrow suppression.
Lactic acidosis.
Lactic acid. Yeah, you have a 53-year-old man. He's day one after an uneventful emergency laparotomy for a gastric perforation. He was unwell for a week, self-medicating with paracetamol and NSAID drugs. So, what is the likely cause of the liver injury? What is the treatment? What laboratory values which are not displayed here are crucial for the prognosis? PCM, drug-induced liver injury. Yes, very good. Paracetamol poisoning, paracetamol toxicity. A drug-induced and the liver injury is a better answer. Pallavi, yes, INR is very good. Paracetamol normogram, a nomogram you meant. Okay, so I don't think so. It is required right now. Okay, so NAC infusion is the treatment. Yes, very good. So then, any other laboratory values? Lactate, pH, INR. Yes, okay. The creatinine is already there. So to know the scoring system for the paracetamol induced the liver failure, to know the prognosis, you need the pH, you need, I think, clinical assessment as well to see for the grade 3 or a grade 4 encephalopathy, the creatinine, and also the PTINR, pH, PTINR, yes. Yeah, INR, pH, creatinine, prothrombin time, and ammonia. Yeah, 27-year-old man, the previously fit and well, developed worsening agitation over a couple of days and is now admitted to the ICU. So no known use of drugs, no allergies. What is the likely diagnosis? What is the treatment? Acute bacterial meningitis. Okay. What is the treatment? Steroids and antibiotics. Okay. Anything else along with the treatment you would like to do? Looking at the WBC count. Okay. 957, the WBC count is actually a very large count. Steroids. Anything else? Abscess to rule out. Yes, very good. Saha. Yeah. So if you have WBC count of like more than 200, so you should suspect any abscess. So you should rule out with imaging. Yeah, I think so. We are done with the CBS. So I'll go with the CCS one.
Yeah,
Just a minute.
Dr. Manjunath,
Yeah.
before going to the CS, few
Mm-hmm.
highlights of the session. I know
Mm-hmm.
completely, and I also advise the attendees that look, when we are discussing in a group, so many answers are coming. But in the
Mm-hmm.
exam, when we are only getting 1 minute per question, believe me, it is one question per, like 1 minute per question. So you will not be getting so much of time to like no answer or enumerate like no 1, 2, 3, 4, 5. And it's the discretion of the examiner to select the best options in the answer list. There would be almost 8 to 10 answers. Like every question that we discussed today, we all know the attendees have suggested also many answers which are correct, but we don't know, like no, we also, because the examiner who is framing the question, so they only know that what are the correct options and the answers, like no, that would be getting the marks, that would be fetching the mark. So that is point number one. So we should be very prompt in highlighting the most important or the emergent or the critical care prospective important things. That is point number one. Now, the second point, there was a query in the glioma. I completely agree. So the glioma is one of the highly vascular tumors. So thrombolysis would be least preferred, but it is not that you cannot give. This is not like if you are getting a patient with like no the severely hypotensive and the patient is having massive P, so definitely this is one of the treatment option. But completely agree with the forum that yes, it is one of the option that we can give in the third or fourth option. So just to highlight about that question, so what are the treatment options? Definitely that patient is really serious. So starting with direct oral anticoagulant, low molecular weight heparin or unfractionated heparin would not be advised in completely like you know, the unstable patient. So now remains there is option of mechanical thrombectomy and thrombolysis. IVC filter is again for prevention part. But at this point of time, just putting the patient when the patient is sinking would not be a very advisable thing, because the already the thrombus has actually lost in the terminal bronchus. So we are only remaining with mechanical thrombectomy, but again, that requires specialized expertise. So you have to mention the options that is available as like mechanical thrombectomy, thrombolysis, but yes, with extreme caution. Extreme caution is required in glioma patients due to the high risk of intracranial hemorrhage. But if you do not have any other option, then definitely thrombolysis can be considered or reserved for massive P causing hemodynamic instability. This is point number one. Now, there are certain things that you should remember, and I think when we are discussing about such an important topic of pulmonary embolism, so the grade and location of glioma is very important. As we have already told, high grade glioma, particularly glioblastoma, they have a high risk of intracranial hemorrhage. Recent neurosurgical procedures, there was one question 2 years back when they have not mentioned glioblastoma, rather they just mentioned about decompressive craniotomy has been done 48 hours before. Now the patient is in ICU and presented with pulmonary embolism. So again, a very difficult situation. So 48 hours, you have to avoid anticoagulation for at least 24 to 48 hours post surgery. So what is right, what is wrong, difficult to say. But yes, this is one of the clinical factor you have to consider before going for the final decision. Now, risk of bleeding, always you assess the bleeding risk and renal function when you are discussing about or considering low molecular heparin or DOACs. So definitely renal impairment is one of the limiting factor for going forward with the low molecular heparin or DOAC. And finally, sometimes patient preference also and quality of life. In European exams, sometimes that also comes into the picture. But the recent evidences, whatever is there, so low molecular weight heparin may be safer than the DOACs in glioma due to low risk of intracranial bleeding. If there is a the confusion between LMWH versus DOAC, so it's always low molecular weight heparin as per the recent studies. So this is something from my side. And yes, the questions somebody has posted, where is the curve and the graphs? So we are only limiting the discussion to some of the important questions in the biochemical, because curves that we have seen in the last 2 to 3 exams, it is all related to ventilator graphics, ineffective triggering, some of the ICP waveforms, and Dr. Manjunath would be highlighting that also in the last part of the presentation. What are the important things that to be discussed? Because if we will be discussing, it would be almost taking 50 questions. And I don't think at this point of time, when you are all starting to prepare or already prepared, so to discuss each and everything, because there would not be right or wrong completely answers. There would be many answers would be coming up, and that may not be the exact perspective with which we have thought about this webinar. Yeah.
Yeah, Tapas, I think you've rightly said. So I discussed with like same question with the neurosurgeon and the cardiologist as well. So what they feel is they all think about this the mechanical thrombectomy only with the high grade and gliomas and the gliomas which are actually more than 3 centimeter in size. So that's the reason. So I put it as the mainly and thrombolysis. So yeah, and if you want to tell the answer in the exam, you can say like both as well. But specifically, when they put it as glioma, the patient was on steroids and all that, I would go with the thrombolysis. And yeah, we can say the both as well. And I think the somebody has put it as if strep strepto suspected steroids. So see, and you cannot say each and everything here. So they given you scenario of the CSF and with the WBC count and all other the factors which leads to uh, which actually collaborative for the meningitis. So best answer is to what start the antibiotics with the meningitis dose, the ceftriaxone and vancomycin, and then the following that and the steroids, and then CT brain to rule out the abscess.
Yeah, completely agree. Dr. Assis, you have mentioned about why we have not mentioned ABC. Believe me, we got feedback from the last to last examinees
Last thing.
that mentioning ABC is something right now the examiners are not very keen to listen to from the examinees. So rather they are mentioning that it's like the treatment. And when we are discussing about treatment, it is the most definitive treatment or the most important treatment. Now everyone, we also agree, in the emergency department, in the critical care department, whoever starts airway breathing circulation. So that's not something new. As like intensivist or emergency physicians, we are supposed to take care of ABC. So I completely agree that we can mention that, but that is not something which would be fetching mark, because we got the feedback from our candidates. So
You will not have a separate like marks for the ABC there. In the CBS, especially the specific treatment and whatever they have asked for, and you should tell in the exam. If you start telling no, I'll take care of airway breathing circulation, the 2 minutes are done over there.
yeah. So if you can start with, it's okay, but expecting that that would be getting you more marks or like something which would be differentiating you from some other candidate may not be appropriate. Again, it's all assumptions. We are not the examiners in the European exam board who is which is taking the exam. So maybe we should be telling, I am not saying that we should not mention, but specifically it is the answer of choice. I don't think so.
Saying ABC would be good, but you should, I mean, whatever is the important thing should not be missed after saying ABC. I think you start saying management of ABC, and in the meanwhile, you can figure out what is the exact answer they're expecting. I think you should complete that answer. You don't say that answer, I don't think, but by just saying ABC, it will be of any help.
And last thing, because if you are all expecting that more number of questions to be discussed, we have to respect everybody's time, because we got feedback from candidates that it should not be so much prolonged, 2 hours, 2.5 hours. We are just discussing the questions. Rather, the important high yield domains, if we can discuss that would be more useful than like one prototype question about meningitis, and that we are discussing so many options like what we have right now over 30 minutes or so. There were like 97 responses for the 10 questions. So, and we in our course would be incorporating the questions appropriately in the respective domains. That would be more useful when you read something and you are answering those questions or like attempting those questions in the practice test. We have enough practice tests every weekend, so that would be more, I would say, the pertinent to the discussion rather than discussing everything now and just forgetting about like what are the important things that to be read. Yeah, Dr. Sanand, anything you want to add at this point in time before
I
Dr.
think he has already,
I think Sanan sir is
I think
already
he's already
typed, no
mentioned.
ABC in CBS, please. It will not be helpful and can be counterproductive.
Yeah,
He's already
so,
put it.
uh,
It doesn't help. It doesn't help at all. This is specialty exam. Nobody wants to hear about ABC in a specialty exam. So
Dr.
it's true.
Dr. Ashish, don't feel that we are not for ABC. We will be also doing ABC, but it was before 8 years when we were taking the exam. So definitely at that time, but now the examiners are very they very clear about what they expect from the examinees. So better to not go for all these things to just buy time. So the examiner would know that he is trying to beat around the bush. Yeah. Okay. So, Dr. Manjunath, please, for the CC.
Yes, yes. You can see the slide.
Yeah, it is visible. Yeah.
Yes, sir.
Yeah.
Visible.
So, this is the CCS and the scenario which was recalled by one of the candidates. So you are in charge of the trauma team in the tertiary major trauma center in the large university hospital. The history was 48-year-old woman was crossing the railroad, so making a phone call. A train coming from her left side hit her. On arrival of the emergency medical crew, she was unconscious. The GCS of an 3, cyanotic with a systolic, the BP of 60 mm. She was intubated at the scene without the use of drugs, and bleeding of the scalp laceration was stopped by compression bandage. One intraosseous cannula was placed into the right tibia because of the poor peripheral access, and 1 liter of crystalloid was given during the transfer. The transfer to your hospital took around 35 minutes. The past medical history is unknown. So on arrival to your department, the patient is in extremes. There is no additional information from the ambulance crew. Oral endotracheal tube, the 7.5. The breathing on ventilator with a 70% FiO2 with all the lung protective ventilation measures. The chest seems to be expanding normally, no surgical emphysema, but rib fractures are palpable. The breathing sounds are diminished on both sides. The worst on the right side. SpO2 is not measurable because of the poor signal. And the circulation, the visibly pale, the pulse palpable from the large vessels. The systolic, the BP is 45, the bradycardia of 45 per minute. GCS of 3. She had no sedatives, and so far the pupils are symmetrical, the 3 mm with a sluggish response to light. She occasionally triggers the ventilator. On the other all extremities examination, the bandage around the head soaked with the blood, cervical collar is in place, abdomen is soft and not distended. The bleeding laceration 10 into 15 centimeter with protruding or lacerated muscle just above the left popliteal fossa, two lacerations on the left elbow, and there are no obvious fractures or deformities of the extremities. Bladder temperature is around 32.7 degrees Celsius. So initial investigations, I think, yeah, 1 liter of warm Ringer solution is commenced to an intraosseous line. An arterial line is inserted into the right femoral artery, but attempts to secure the peripheral IV access failed despite the 4 attempts. The blood sample obtained from the arterial line shows the following values. So you have an ABG, the values here. So when you have a lady with who was hit by a train while she was talking over the phone, so she has got some chest injury. She's in shock and low GCS. So what are the major diagnoses in this case? What are the likely cause of the shock in this patient? Describe the initial management of this lady. Oh, hypothermia, hemorrhagic shock, pneumothorax. Okay, fine. So I can't wait for all the answers. Okay. So what are the major diagnoses in this case? She has got a chest injury. She's in shock. She's a case of like a polytrauma, inclusive of the TBI, high suspicion of the severe TBI. So because the GCS is around 3/15, the shock, hemodynamic instability, the probably thoracic trauma, uh, and ABG shows high lactates with metabolic acidosis. So the major diagnoses are case of polytrauma, the TBI, most probably mainly hemorrhagic shock, and the thoracic trauma, hyperlactatemia. So what are the likely causes of the shock in this patient? The blood loss, hemorrhagic, pericardial tamponade. So we should rule out still tension pneumothorax and the spinal injury. So when you need to mention all this in the exam, okay, what are the likely causes? You cannot simply say it's only hemorrhagic shock. And you might have to consider all the possible things because we have not still done with all the imaging here. Okay. Describe your initial management of this lady. First, IV access. How you do it, it only gives the points of, especially you should tell that, okay, I will do ultrasound guided or CVC or the surgical venesection. So they've already told you that the peripheral and the venous access was actually difficult and they have done intraosseous access. So the first is IV access. And then comes the activate the massive blood transfusion, the protocol. So because the patient is with like BP of like 45 systolic and high lactates, acidosis, blood loss, and perform ultrasound examination of the thorax and abdomen, mainly EFAST and protocol. If if at all if you mention the CT here, the patient is hemodynamically unstable. So I don't think so, and you will get any like marks if you tell about the CT. I think you should tell like the first thing is EFAST to rule out the mainly the solid organ injuries and the pericardial under tamponade, and we don't know exactly, and you might have to apply the pelvic binder as well. So because patient in shock is suspected to have any, if they don't have any long bone injuries, so you'll have a high suspicion for pelvic bone fractures. So then comes, so you have the next vignette, thromboelastometry was obtained. So this is the thromboelastometry. So extem and the FIPTEM. So you have all these in values here. I'll not go in detail of this right now. It will take at least 1 hour. So, and you have EFAST scan. Extended fast scan of the right side are shown below. There was no free fluid on the pictures of the left side and the pelvis. So whatever is significant, and I put it here. So this is the image of the right side and the thorax at the mid axillary line. So you have fluid inside the pleural cavity underlying under collapse, the probably hemothorax. And left side abdomen, the mid axillary line. So, and you can see a hepatorenal pouch here, and also on right side abdomen, the mid axillary line. Our right side is hepatorenal. This side is actually under splenorenal pouch. So, and you have this, the mainly the thromboelastometry in the next vignette, and then comes the ultrasound images, and then comes M mode. below the clavicle, right and left. So what you can see here, how do you interpret the ultrasound images? How would you manage the thoracic trauma in this patient? Describe how you would insert the chest drains. How do you interpret the thromboelastography? How would you correct the coagulopathy? Please name the blood components, the products, and the approximate and the doses. These are the probable questions what you get in the exam if you get a trauma case. So, and you should be aware of all the doses of the blood components and the products and the TEG or the FIPTEM. How do you diagnose it? And also the procedure for the how to insert the chest drain. How do you interpret the ultrasound image? The left side pneumothorax or pneumohemothorax and right side hemothorax and no free fluid in the abdomen. Hepatorenal pouch was fine. So then comes how did you manage the thoracic trauma in this patient? Chest drain like both sides. First is a needle decompression on the left. Describe how would you insert the chest drain? First, you should tell the triangle of the safety and fourth intercostal space, mainly laterally. And the technique, you can say the dissection or the finger sweep in the technique as well. And then you all confirm the drain placement, whether there is a swing of the swing or draining or it is still hazy. So you should be aware of all this to vocalize in the exam. How do you interpret the what thromboelastography? So it is the value and whatever you can see, it shows the more of the trauma induced undercoagulopathy, lack of the fibrinogen, and there is no hyperfibrinolysis at present on the TEG. So how would you correct the coagulopathy? The fibrinogen, the base on the FIPTEM. So it's around like 4 grams, and the tranexamic acid, the 1 gram, the bolus, and 1 gram well, every and 8 hours. So, and you should tell the dose until and unless if you don't tell the dose, and you might not get the like the full marks. And if they ask you specifically in the question that please mention the dose of the products, and you should tell the dose. And FFPs 1:1 ratio. Okay. On the this is the second vignette. Dialysis catheter was inserted into the right subclavian vein, and the patient received around 4 units of like warmed O negative blood because of a massive blood transfusion protocol was activated, and the 4 gram of under fibrinogen and the 1 gram of under tranexamic acid. More blood products are still coming. Large bore intercostal the drains were inserted into like both chemithorax. The right drain is around 1950 ml, so which is actually significant for you to take a next call to whom to get involved here. Now it has stopped draining, but it is still swinging. The left chest drain only drained air. The vitals improved on FiO2 of like 50% now, the saturation of 100% with a good trace, BP of 110/40 and the heart rate of around 135 per minute. And the radial pulses are now palpable. Just radiograph is performed and you can see the X-ray here. You can see the ICD, you can see the lung expansion, you can see the ECG leads, all that. So then comes, what is the next plan? The patient is become like stable now. So I would like to do, because there is around 1.9 liters of the blood, I would like to involve the cardiovascular surgeon, the CTVS and the surgeon. The patient actually might need a thoracotomy. And I would like, because the patient is like stable, I would like to do the polytrauma CT of the whole body. And also because the patient received multiple the transfusions, check the calcium and also supplement it and check the coagulation as well. Always you make sure that you take care of the triad of under trauma here: hypothermia, acidosis, that and coagulopathy. The whole body CT was performed and shows the like following injuries. It's got some on right side the temporal lobe contusion, the traumatic SAH, and the base of the skull fracture. The base of the skull fracture is very important here. And the basal systems are preserved with a midline shift of less than like 5 mm. So the patient actually does not require any intervention right now. The bilateral, the multiple rib fractures without clear what flail segment. The spine, unstable fracture dislocation of L1, so, but without any bony fragments in the spinal column or, or clear signs of the spinal cord transaction. And the X-ray of the extremities did not show any long bone fractures. The when the cervical spine was cleared as per the local protocol, the patient received around 10 units of the packed all red blood cells, that 10 units of FFPs and one bag of and the platelets, and she is now hemodynamically stable. The lactate decreased to 4.4, hemoglobin 12 gram. The rotum is actually normal. The bladder temperature has improved 34 degrees Celsius, and there is no further output from the chest drains and no sign of cerebrospinal fluid leak. So this is the image you can see. Unstable fracture dislocation of all L1. So this is the CT brain image. You can see here right temporal lobe contusion. So and traumatic subarachnoid bleed in the base of the skull. Base of the skull you can't see in this. So these are the questions and what you can expect in the exam. What are the pros and cons for proceeding with the spinal surgery at this stage? And together with orthopedic surgeons and the neurosurgeons, and you decided that the spinal surgery has a priority and will happen in like few hours time. What are your management goals in terms of like BP and the target hemoglobin, the fibrinogen and the platelet count? What other parameters need to be checked and corrected before the patient goes to theater in order to minimize the risk of secondary brain injury? And discuss the role and the timing of antibiotic and prophylaxis in this patient with regard to the base of the skull fracture and the planned spinal surgery. Would you consider any other prophylactic anti-infective measures apart from antibiotics? So what are the pros and the cons for proceeding with a spinal surgery at this stage? Pro, unstable spine impairs the TBI management. Patient cannot sit upright here. But the pro, we need to protect the spinal cord here. And the con, proning for surgery may worsen the brain swelling, and we might have to do ICP monitoring and then go ahead with the surgery. And the cons, yeah, and the hemodynamics may deteriorate again, the chest stability during proning, and potential bleeding under coagulopathy. All these are expected things, and you might have to take the priority and get the surgery done. Along with orthopedic surgeons and neurosurgeons, and you decided that spinal surgery as a priority and will happen in the few hours time. What are the management and the goals here? The map of like more than 80 has TBI is present. If you, if at all, if you tell that okay, I will maintain the CPP and all that, and you might, so they might ask you, have you done the ICP monitoring and all that? So, and you might have to say in the pro and the cons of the spinal surgery that I would like to do an ICP and go ahead with the surgery, and I can monitor the ICP throughout the surgery and also monitor the cerebral perfusion pressure. It will be a better answer like for you in the exam. And the, and the hemoglobin 7 to 9 gram, and the platelet, yeah, more than 1 lakh, and the fibrinogen more than 1.5 to 2 gram per liter. So, and you can also say intraoperatively, I would like to do the thromboelastometry and take a call about it. Okay, what other parameters all need to be checked and corrected to minimize the risk of the secondary brain injury? All the neuroprotective measures and whatever you do, in your ICUs, and you should tell that the PaO2 of like more than 10 kilopascals or like more than 78, ensure the proper sedation analgesia, the PCO2 of around all 34 to 38. Consider ICP monitoring. Yes, high normal sodium osmolality of around 145 to 150. So the role in the antibiotic prophylaxis in this patient regard to the base of the skull fracture and the planned spinal surgery. Base of the skull fracture without the CSF leak is not an indication. Antibiotic prophylaxis is indicated for the spinal surgery with likely instrumentation. So when you might have to say, yeah, I would like to start on uh, cephalosporins or uh, augmentin. So and a single dose is accepted. If there is prolonged surgery or blood loss, then you might have to repeat the dose of antibiotic. And due to muscle injury and the scalp laceration, and the surgery, antibiotic and the treatment might be prolonged. So, would you consider any other prophylactic anti-infective measures? Yeah, tetanus prophylaxis. The check the vaccination status as the deep wounds. The patient had a scalp cut or laceration, the bleeding and all that. And you might have to say that, okay, I will check with the active and the passive immunization. The like a patient, the following that, I'll go with a tetanus prophylaxis. Usually in trauma, if they're asking apart from the antibiotics, any other anti-infective measures, yeah, it will be tetanus. In the Vignette 4, so we are now 7 hours after injury. The patient underwent the posterior stabilization of her lumbar spine. The popliteal wound was actually debrided and sutured. Her spine is now stable and there are no further movement or positioning restrictions. Returning from theater, she had a follow-up head CT scan which showed mild enlargement of the temporal contusion, but otherwise unchanged intracranial findings. The neurosurgeons inserted an intraparenchymal ICP monitoring probe and sutured her scalp lacerations. Like no further procedures are planned, and the patient returns to ICU. And on examination, you find airways secured, SpO2 100% on FiO2 of like 0.5, the PEEP of 8, heart rate is okay, the MAP 81 with all on noradrenaline support, the deep sedation, the cervical collar in situ, and no signs of the bleeding. The bladder temperature is better, and you have this ICP monitor here. How do you assess auto regulation of the cerebral perfusion? Sorry, I think you can see the ICP, the wave here. See the gradings as well and the time as well. Yes, yeah. How do you assess the auto regulation of the cerebral perfusion? Explain the mechanism. How do you manage the raised ICP in this patient at this stage? What are the safety limits for osmotherapy? Is a temporal contusion of any significance, and does it influence the management of this patient? After 24 hours and after optimization of the sedation, including relaxation and on hyperosmotic therapy, ICP is still out of control. What would you do? Please comment on the evidence behind the rescue options. What is the role of hypothermia in the management of raised ICP? How do you assess autoregulation of the cerebral perfusion? Explain the mechanism. So we all know how do we calculate the MAP, the mean arterial pressure, and also you can see for the autoregulation. Vasoconstriction, if the MAP is higher, there'll be drop of ICP. And you should be able to know how to answer in the exam. The change in the transcranial Doppler, the change in the cerebral oximetry, all that actually manipulates the MAP. So then comes how do you manage the raised ICP in this patient at this stage? Yeah, remove the C collar, the sit upright, deepen the sedation, paralysis, hypertonic the mannitol or hypertonic saline. What are the safety limits? Yeah, up to 145 to 150 or up to like a 155 as well. Osmolarity up to around 320. Is a temporal contusion of any significance? And does it influence the management? Yes, it may be epileptogenic, especially temporal and frontal contusions. EEG is highly recommended. Okay. And after optimization of under sedation, including the relaxation and on hyperosmotic therapy, ICP is still out of control. What would you do? You will repeat the CT scan. You will ask neurosurgeon for the decompressive craniectomy. Please comment on the evidence behind the rescue options. Yes, the DECRA trial. So no benefit of the decompression in the RCTs and mild hyperventilation driven by the if you have done the Zugler oximetry and microdialysis, the cerebral dialysis and the brain oxygenation, yes, and you can consider that. And that thiopentone infusions, but there is no good evidence as well. But decompressive craniectomy at this point of time, if it is still out of control, if the CT is showing again increase the cerebral edema, I would like to go with the decompressive craniectomy. But you should be aware of all the evidences here as well. What is the role of hypothermia in the management of all raised ICP? There is no role, and you have seen with a trial called an Eurotherm trial, the worst outcome in the RCTs. Okay. The Vignette 5. The patient underwent decompressive craniectomy for the refractory intracranial hypertension 5 days after admission. Over the next few days, ICP therapies and the sedatives are stopped. She had an early tracheostomy. It is now day 10 after admission. She's spontaneously breathing on a ventilator with a minimal pressure support. She's hemodynamically stable and receiving full enteral nutrition. On neurological examination, she is not obeying commands but has a symmetrical flexion in like both the arms and intact brainstem reflexes. CT of the brain at day 10 after injury, and you have this CT. You can see the post decompression in the status here. Then comes you have a meeting with the patient husband. So his mother actually died of hypoxic brain injury a month after successful the CPR. He is concerned that his wife has no chance of recovery and wonders whether ongoing active treatment is all justified. What do you answer? See the scenario again. She's a young lady who is now recovering. She has undergone the tracheostomy. She is spontaneously breathing on ventilator with minimal support. She is hemodynamically stable on good nutrition. She is not obeying commands, but she has a symmetrical deflection in like both the arms and intact brainstem reflexes. The CT brain is acceptable just because he had the past experience of his mother died of hypoxic the brain injury. He is thinking of whether ongoing active treatment is actually justified or not. What do you answer here? I would answer aftercare is actually justified at this stage. It's too early to consider for any withdrawal. If at all, if there was no brainstem reflexes, if she was not tolerating the weaning, if she is not triggering the ventilator, yeah, I would have considered for the withdrawal. So, but she is on the weaning. She has symmetrical deflection of like both on the limbs. I would consider active care. Outcome is uncertain, so but some improvements are likely. So, and you can say, I would like to go ahead with a neuro rehab therapy in the coming days. And considering her age, considering her all the improvement for the last under 10 days, so we might expect actually all positive outcomes in her. The traumatic etiologies have generally better prognosis than the hypoxic injury, and younger age is associated with better prognosis. MRI should be performed before prognostication or any decision making. Compassionate care may be considered when later if there is no improvements over time. Oh, yeah, I think this is done with the CCS.
Sir,
So this
last
is how.
part. Sir, should we involve
Mhm.
the neurologist or the physiotherapy rehabilitation team? Should that be added to it, or when we are
See,
prognosticating?
no, because in the scenario and you have a meeting with the patient husband, so I did not include all of them. So, but if at all, if you're considering the MRI, yeah, multidisciplinary team meeting with the neurologist or neurosurgeon and also the rehab therapist is important here.
Okay.
Yeah. See anything here? Yeah, chat has polytrauma, hemorrhagic shock, bilateral ICD. Okay.
I think no queries from the attendees, I think.
Oh, 74. Oh, big attendance today.
It was more than 70. Attendees alone was more than 70. I think 72 was maximum. I think few have left the
Okay.
discussion.
Okay. Any questions? See, this session was actually mainly to make you guys understand how was in the last exam. So, what are their expectations in the exam? And also, I think for you guys to have a roadmap of preparation, how exactly you guys should exactly under concentrate. I understand a few people were answering about the steroids for the step two, and a few were actually um, asking about all the different things. But see, be straightforward in the exam. Okay, don't think all the rarest things. So whatever you have the scenarios there, please try to answer and the straightforward to those scenarios. If at all, if you try to think and overboard with all the other and the knowledge here, you might actually end up in not getting the perfect answer in the exam. You might answer, but your answers might not be perfect for that scenario. Any comments from anyone?
And this, I think CCS is similar to what we got in our exams.
Yeah.
Yeah. So the I mean, the rail traffic accident, and our case also was a female who went into
Mhm.
DIC, then management of DIC, trauma management, then sepsis management. So that is all
Yes.
7 years back, we had similar question. Both of us had the same thing.
And I still remember, I think I had not answered about the tetanus prophylaxis. I was just telling them about, I think, the WAP bundle or something. Any comments, anything?
Manjuna, this is Sanant here. I think you have
Uh,
done a great job. Sorry, I was a bit
Sanant.
patchy in my attendance because I'm traveling. But I think the bottom line of the exam is be rational to the exam, and like if you think rationally, answer rationally, you will pass very easily. There's no need for any heroics. Very rare condition. We should not be talking about those things. Very general critical care that we do day to day. That's what they want to listen.
I think I'll just take, I think, the 5 more minutes. I have this on the PPT, which I think I'd prepared for the on the last batch as well. So we'll just go through this. It has hardly some, I think, 7, 8 slides. So it will give you a picture how exactly to prepare for the exam. You can see the slides,
We can see, we
Jitendra?
can see. Yeah, we can see, sir.
Yeah, okay, fine. So see, for the, especially for the EDIC, the part two, the whatever you sit and read in that only the 10% comes. Whatever you see daily in the ICU, that at least 30% you can see and diagnose and answer. Okay, so don't sit and read for the exam. If you ask me, you should be working one day before the exam as well. The scenario, the whatever you see in your ICU, it might come in the exam as well. So, and 20% of what we hear, we actually remember, and 90% of what we say and we do daily that. Okay, this is especially for the like a part two, and I think most of the people follow this. And don't waste your time in lot of theory and reading all these the mechanisms and all that, so it will not actually fetch you marks in the exam. It's all about in that specific time how exactly you analyze the scenario and answer them immediately. So always you work on the approach and the treatment like for all the case scenarios and be specific in your answers. Okay, the CBS and the stations, and you have around 10 to 12 minutes. The time constants is like most important and the most dreadful, I can say. The read question carefully. Don't jump to the images, because if you see the scenario, I think 30 to 40% of the clue and you will have there, and stick to the question. Look at the image or the videos and carefully. And for this, and you should do lot of and practice sessions. If you have time, go and meet your all the radiology the colleagues and ask them how to read the CT or MRI, the abdomen, the CT abdomen. Try following those steps. This is like most important thing. I think the most of the time, so you all say only the Winter's formula, the first diagnosis of the ABG, and there are all double disorders and the triple disorders in the all ABG. If you know those double and the triple disorders, and you can easily tell the diagnosis. So, and your on the thought process and approach should be as soon as you see the ABG and you should have a diagnosis. Okay, so the formulas for compensation, osmolality, corrected calcium, and the anion gap, all these are very important. And practice in such a way that you should be perfect with all the differential diagnosis like for each disorder. If at all, if gap ratio is less than like zero point 0.4 to like zero point 0.8, more than zero point 0.8, all that. And calculations will not consume much of the time until and unless if you practice it every day in your ICU practice. Okay. And I would suggest a life in the fast lane, the website for ABGs. I think so. They have around 150 ABGs of the scenarios. And if you do that, if you do daily 10, it's like more than enough. The next, I think around 2 to 3 weeks, and you can finish it off. And diagnose ABG on the causes of acidosis. See, there is pupils are bilaterally absent, directly flexes, the severe acidosis, measured osmolality, calculated osmolality. It's all, see, every parameter is important here. So the please don't jump to the images or whatever the lab findings they've given. Please read all each and everything here. And if they have given the laboratory and the parameters, the most commonly it will be the DK, HHS, the central DI and SIDH, the mixed edema coma, and the thyrotoxicosis. And if they have any scenarios with the thrombocytopenia or acute kidney injury, it will be HUS and the TTP or DIC. Or if the patient has undergone surgery with thrombocytopenia and the post that heparin-induced thrombocytopenia and the tumor lysis syndrome, the refeeding and overfeeding syndrome, and the toxidromes and the toxic shock syndromes. Okay. The images, I think, always read the scenario and then see for the abnormality. Follow the basic rule: the skin, soft tissue, the bone, and the parenchyma. It is for anything, it is the skin, soft tissue, bone, and parenchyma. And X-ray or pneumothorax, Ogilvie syndrome, and also see for all the hardware devices in that. The CT scan, the brain, don't forget to mention the midline shift or location of abnormality and the features of the cerebral edema, the gyre and sulci, and all whiteout of the parenchyma, all effacement of the sulci, all that. And the CT abdomen. So if you have a CT image of the pancreatitis, they might expect the CT severity index. And practice in your patients and whatever you have in your intensive care unit. And Ogilvie syndrome, the treatment, and pyelonephritis, what all the findings you see in the CT abdomen. Ultrasound, like short videos, yeah, can be played with around 4 to 5 seconds, all correlate with the scenario. See in your daily practice the pneumothorax consolidation or dynamic air bronchogram and the static air bronchogram, stress cardiomyopathy, how exactly it looks, apical ballooning, ventricular septal rupture, the probably the post MI after the third or the fourth day, the patient is in shock, all that. All these will be the scenarios. The trauma patient, the free fluid and the vascular injuries, and the transcranial Doppler, either you will have SH or brain death. And this arterial BP and IABP, yeah, and you should be aware of all this, all over damped trace, under damped trace, low dicrotic notch, high dicrotic notch, all that. And the ventilator graphics, I think at this time, so most of the students were telling, so we had some scenarios on the ventilator graphics. See, the scenarios will have, and you will have the, I think the scenarios of around 14 to 15 scenarios of the ventilator all graphics, and you should know especially the scalar and the loop and the following that, how to diagnose on the low compliance and the auto peep, the leak, asynchrony, bronchospasm. If at all, if you know all this, I think the most of the scenarios will be tackled regarding to the ventilator graphics. And for this, you should practice in your all the daily ICU shift on the bedside. And clinical case scenarios, I think the three different vignette you will get 30 minutes before that, and utilize those the first few minutes very effectively. Or write the differential diagnosis or the provisional or diagnosis. Have your the thought process that, see, if at all if I get a GI bleed, I will think of endoscopy, then the pantoprazole infusion, then the following that the massive transfusion if it is required, and then comes if it is a CLD patient, the patient can have some all SBP and other HRS. Patient might require any dialysis and all those things. So you should have that on the thought process, and as soon as you get the on the first vignette and summarize the case with all the differential diagnosis, approach should be in the clinical case scenarios, yes, but not for the CBS per se. But here you should say, okay, if at all if there is any change in the scenario, in the sense, and you had a patient with a in the vignette one was actually stable, in the vignette two they have suddenly changed it that the patient has a shock, has got a, like a bleeding, has got some and acute kidney injury, he has or worsening acidosis, yeah, I would like to do the assessment. If at all, if they ask you how do you approach, yes, start with ABC here. The point out all the significant history in the scenario. Okay. In the polytrauma, yes, the first thing is or TT or tetanus and the toxoid, the primary survey, all the adjuncts of the primary survey, X-ray, ECG, the Foley's catheter, all that. Two large bore IV cannula, IV fluid, hemorrhagic shock, the massive transfusion, the tranexamic acid, and the polytrauma team. Yeah. And you might have to say, and the ER team, anesthesia, ICU, general surgeon, plastic surgeon, neurosurgeon, orthopedics, the manager of the triad of trauma-induced coagulopathy. All neuro cases, yeah, involve all neurologists and the neurosurgeon, all neuroprotective measures, or any change in the GCS in the scenario, ask for the CT scan. Any worsening general condition of the neuro case, the sepsis complication of the primary problem, SCH or the meningitis. And the tracheostomy, you should know the evidence. Most of the time, all the neuro cases actually end up in all hospital acquired infections, the VAP, the CRBSI, the COTI, antibiotics. And you can say, I would start antibiotics as per the all ICU nosocomial epidemiology. And then they end up in all critical illness and neuromyopathy and the rehabilitation program, and they might actually land up in end of life care. The GIT, I already told. Yeah, the pancreatitis, you should know the management, how you interpret the CT scan, and then comes abdominal compartment syndrome and the sepsis. Cardiovascular, yes, ECG, ACLS, defibrillation, when exactly you do. Out of hospital cardiac arrest, like brain dead, IABP, ECMO, when do you start antiplatelets, anticoagulation. Yes, and the respiratory, I think this is the bread and butter and ERDS, the definition, approach for hypoxic patient, the ventilator and the non-ventilator strategies, the prone, physiology, evidence, ECMO, VV and VA, critical illness neuromyopathy. Obstetric scenario, be aware of all the physiological changes, the pre-eclampsia, eclampsia, the PPH, always involvement of the IR team for embolization, the massive transfusion, the peripartum, cardiomyopathy. You should know the definition, the management, counseling the patient for the future pregnancies. End of life care discussion, the speak with empathy, the compassion, always mainly highlight the all age of the patient, the background illness, and always talk to the next of the kin, the prognosis, the benefits and the risk of the treatment, and also consider the quality of life, how exactly it was all before the illness. And if the patient has any living will from the patient, you should ask for it. And you should know the brain death guidelines and the end of life care guidelines. See, things you should always search for that teach each other. And you have two people in your team who are actually while giving exam, so you should always practice with them. And see, apart from that, you should always do a smart work here. Create the pictures, draw the diagrams, the mind maps, and turn the abstract and the theory into action and images. And you should always calculate the formulas of all ABG into your practice and avoid multitasking and eliminate the student syndrome, the sitting with the books and reading, taking leave from your all duties, the sitting and studying. No, it is not expected for the EDIC part two. You should practice, you should make sure in your daily practice and whatever you're seeing the scenarios, the same scenarios it will come in the exam. Okay. Yeah, I think I'm done. There's some issue with my PPT. Yeah. I think I'm done. Stop sharing. Yeah. Anything else? I think, and you're all in the group. So if you have anything, any doubts to be asked, and you can still, we are expecting more and more during the course. Yeah, Mohammad Ragan. Yes. Sriram. Thank you, sir, for your time. Welcome. Shall we wind up? Jitendra?
Yes, Dr. Manjunath, it
Yes,
has
sir.
been a long session, I think.
Yeah.
Yeah.
As Dr. Raga rightly said, we'll be meeting. We'll have more interactions.
We need more scenario for, I think, the ventilator graphics. Yeah, sure.
You're all still there on the WhatsApp group, so anything is there, you can give us the feedback so that we'll try to cover them. Most of it will be covered in the modules. If something is missed out, I think we'll cover it in the last.
So we have few sessions on the miscellaneous as well. So we'll cover all those in those on the sessions. Okay, so thank you. All the best for the preparation. See you again in all the modules. Take care. Good night.
Thank you. Thank you.